Today we'll be discussing allergic rhinitis and the drugs used to treat this disease process. Allergic rhinitis has many signs and symptoms. They can be characterized as nasal and non-nasal. Nasal include rhinorrhea, sneezing, congestion, and itching, while non-nasal could include redness of the eye, itching of the eyes, and coughs. Children may present with these signs and symptoms differently, including sniffling and snorting. Any prevention methods could be anything from having a face mask or physical barriers, including sunglasses, to limiting direct contact with the allergen, as well as using an AC or air purifiers with HEPA filters and checking pollen counts before going outside.
So for our drug classes and medications, over-the-counter medication used in the treatment of allergic rhinitis, we have our glucocorticoid nasal sprays like fluticasone and budesonide. We have our oral antihistamines, second and first generation agents, cetirizine and diphenhydramine, to name a few. Antihistamine nasal spray like olopatadine, and then oral antihistamine decongestant combinations like loratadine, pseudoephedrine. We have mast cell stabilizers, cromolyn nasal spray, and then nasal decongestant spray, such as phenylephrine nasal spray. For our glucocorticoid nasal spray, the big takeaway here is it's the most effective single maintenance therapy for allergic rhinitis. Adverse effects, local irritation, and then I have a few with asterisks. These are the adverse effects to consider with long-term use of glucocorticoids, although studies in both children and adults have failed to demonstrate these adverse effects as clinically relevant with the nasal sprays, but regardless, they should be tapered to the lowest dose when symptoms are controlled. Our oral antihistamines, they have anticholinergic effects, some sedation with first generation, so second generation are preferred because they're not as sedating with similar efficacy. Ultimately, the oral antihistamines can reduce some symptoms like itching and sneezing, but they're typically less effective for nasal decongestant than the glucocorticoid sprays. The antihistamine nasal sprays, the big adverse effect to point out here is a bitter taste. So these sprays have a fast onset compared to glucocorticoid nasal sprays, and they have good anti-inflammatory effects, but the bitter taste can be bothersome for some patients. And guidelines typically suggest glucocorticoid nasal sprays in preference of the antihistamine sprays based on efficacy. For our mast cell stabilizers, cromolyn nasal spray, minimal side effects, proven efficacy, but less effective than glucocorticoid nasal sprays and second generation antihistamines. Then we have our oral antihistamine decongestant combinations. Again, the big takeaway here is that the non-sedating antihistamines combined with decongestants like pseudoephedrine provide better symptom relief than either agent alone. And you'll see some additional adverse effects that I have listed aside from the oral antihistamines, and those are the adverse effects associated with the decongestant combinations. You'll see underneath I have nasal decongestant sprays, but these are not to be used as monotherapy. We're going to get into the reasons a little bit later, but it can just lead to a condition that can cause rebound congestion and escalated use. So ultimately, if you're going to use a nasal decongestant spray, you should use it with a topical corticosteroid or an oral antihistamine, as stated previously.
There are many different options for dosage forms for the drugs used in allergic rhinitis. There's chewables, tablets, even syrup for pediatric patients for ease of administration. There's orally disintegrating tablets, capsules, caplets, soft gels. Really just depends on the patient's dexterity, how frequently they want to dose it, and patient preference.
In terms of special populations, when considering these medications, the systemic effects of glucocorticoids via nasal spray is pretty minimal, but pediatrics may have a decreased, may have growth suppression with these products, especially if they're combining them with other glucocorticoids like a child with asthma. So to avoid these side effects, they should use the lowest effective dose and use the nasal spray in the morning. Glucocorticoids may also increase intraocular pressure, which can lead to glaucoma. And cataracts are also a risk factor for glaucoma, so therefore these patients should use caution with these products or see an ophthalmologist to check their risk and intraocular pressure. So I focus on the second generation antihistamines. They have less of an effect on the CNS than the first generation, but they do still have some sedative effect due to the binding of H1 receptors in the brain. These sedative effects in pediatric patients and geriatric patients may also be increased if they're taking other sedatives. So it's just something to be cautious for. Antihistamines, first generation, have been shown to decrease prolactin, which can decrease milk supply in a breastfeeding mother. No studies have been shown with the second generation, but it's just something to be cautious of. And also to be cautious of any increased sedation in a baby that's feeding, because some of these medications are passed through breast milk. Second generation antihistamines are metabolized in the liver and excreted via the kidneys. So any patient with renal or hepatic impairment should use low dosing to avoid toxic levels of medication. So combination antihistamine decongestant products carry the same risk of antihistamines, but they also have an increased risk due to the decongesting component of these medications, which is pseudoephedrine. The FDA states children under 4 should not receive these products due to risk of hypertensive emergency, cardiac dysrhythmia, and death. And these children should use non-pharmacological methods. Breast milk supply may also be reduced by the use of pseudoephedrine due to a decrease in prolactin secretion. Therefore, the risk-benefit of taking these medications should be discussed with a provider. And pregnant patients should try to avoid pseudoephedrine because they are considered category C by the FDA. They've been shown to have teratogenic effects. Geriatric patients should also be cautious when using pseudoephedrine. Their overdoses could cause hallucinations, CNS depression, seizures, and possible death. These dangerous side effects have an increased risk for patients who have a decreased drug metabolism or excretion. And if these products are necessary, these geriatric patients should start with a low dosing. Pseudoephedrine can also be problematic for patients with any sort of renal impairment that will cause problems with the excretion of the drug, and it also can cause problems because pseudoephedrine can increase blood pressure, which can further renal problems for these patients. Like I mentioned, hypertension is a side effect of pseudoephedrine, so patients with baseline hypertension should be cautious and monitor their blood pressure closely. Patients with glaucoma should also be cautious using any sort of pseudoephedrine product because it can increase the risk for narrow angle glaucoma. Patients with high risk of this condition should avoid these products. Lastly, diabetic patients should avoid pseudoephedrine when possible due to increasing blood sugar levels caused by this medication. And if diabetic patients do have to take it, they should monitor their blood sugar levels very closely. Antihistamine nasal spray products are available in a pediatric formulation. Therefore, the pediatric population should use that instead of the adult formulation. It's unknown if these medications are secreted in breast milk, so therefore breastfeeding moms should just be cautious and watch for any signs of sedation in their baby. Similarly, geriatric, there's minimal studies on it, and so geriatric patients should just be cautious and monitor for any sort of side effects. And they are considered pregnancy category C, and animal data shows potential harm to fetus, so they should be avoided in pregnant patients when possible. Lastly, mast cell stabilizers are not approved for children younger than 2 and should only be used if benefit outweighs the risks. It's unknown if this medication is secreted in breast milk, therefore breastfeeding moms should discuss with their provider before using this medication. They're considered category B by the FDA just due to a lack of research. And there's a renal and biliary excretion of the product, so we should just decrease dosing for anyone with renal or hepatic dysfunction.
As we've already discussed prior in the presentation, there are many over-the-counter and prescription options available for different methods. Overall, there are about 6 different classes of medication available over-the-counter listed on the slide. Patients can also be prescribed other medications as well within some of these classes, such as mometasone and budesonide as a glucocorticoid nasal spray, loratadine and levocetirizine as an oral antihistamine, and azelastine and olopatadine as an antihistamine nasal spray. If taking loratadine, you will need to speak with your provider since they are renal and hepatotoxic. For levocetirizine, please note that the dosing for a child would be weight-based and almost half the dosing as it would be in an adult. Also, while azelastine is also available as an over-the-counter medication, it is also available as a prescription form as well, just in different dosage strengths.
Just like any prescription medication, there are potential medication safety issues that can occur with over-the-counter medications. One concern is drug-drug interactions. When antihistamines like diphenhydramine, cetirizine, and levocetirizine are taken with other sedating medications, they can cause an additive sedative effect that could put patients at higher risk for accidental injury. Similarly, when fexofenadine is administered with other QT interval prolonging drugs, it may increase risk for dysrhythmias. And when pseudoephedrine and or phenylephrine are administered with MAOI medications, they put patients at higher risk for hypertensive crisis. Caution should also be used when recommending oral decongestants to patients with a history of any of the listed diseases because they might experience exacerbation with use. Other safety issues that can occur with many OTC allergy medications include hypersensitivity reaction, improper administration, anticholinergic toxicity, and rebound phenomenon. Rebound phenomenon is a reaction that can occur with a use of a nasal decongestant medication due to their intensive local vasoconstriction and irritation effects. This results in increased nasal stuffiness and can worsen with continued use. So patients who present with rebound phenomenon should be advised to discontinue the nasal decongestant and instead take an oral decongestant, isotonic saline drops or spray, or both. And lastly, over-the-counter allergy medication misuse and abuse has been a particular safety issue over the last couple of decades. Pseudoephedrine has been misused to manufacture methamphetamine, and high doses of diphenhydramine have been misused to generate feelings of euphoria. In 2020, there was actually a Benadryl challenge that gained popularity on TikTok, which encouraged participants to take large amounts of Benadryl to induce hallucinations. This trend became so widespread that the US FDA released a statement warning consumers, parents, and caregivers that higher than recommended doses of Benadryl can lead to serious heart problems, seizures, coma, and even death. Advanced practice providers can prevent these medication safety issues by performing thorough history taking and medication reconciliations, reviewing significant drug interactions using evidence-based resources like Micromedics and Lexicomp, and providing patient education on appropriate use and storage of over-the-counter drugs and adverse effects that should be reported.
So like we've said, there's many options for over-the-counter drug treatment for allergic rhinitis. So costs for patients can vary depending on whether they take them seasonally, whether they take them, all year round. They're also offered in generic and brand name options, with generic names being at a slightly reduced cost. So very typically, these medications still need to be dosed every day. For example, an individual using combined therapy with cetirizine and Flonase daily could spend upwards of $550 annually to have both of these medications. For someone taking medications for more seasonal causes with just monotherapy, it could average between $20 to $25 a month. Another example of how this can differ is that nasal crom can be used upwards of 3 times a day. So they could go through more medication and require 2 a month, leading to an average cost of $30 a month. These are just some typical drug packaging for over-the-counter drugs. Again, it shows the variation of administration windows, 72 hours, 24 hours. So just educating patients on the mechanism of action, making sure that they prime the nasal spray before they use it, making sure they understand that Benadryl is as needed and that there needs to be, a window of time where they don't take it to prevent drowsiness and other adverse side effects.
And then these are our references. Thank you.